Next, we move on to the next session, which is going to be chaired by Dr. S. Subhash sir. I call upon Dr. Subhash sir to chair the session. And I would like to call upon Dr. Dhivyalakshmi ma'am to speak on the topic early puberty, the pointers, implications.
So, I thank the organizers for giving me a wonderful opportunity to talk about a very important topic, early puberty. See, the terminology precocious puberty, which is, I think, more endocrinology, it smells more endocrinology. Early puberty smells more pediatrician wise, I guess. So, I will be using the term precocious puberty often. So, these terms are often used interchangeably. So this is a 7-year-old girl child. The child came for a routine checkup. I know this child because she comes for the past few years with me because she was born SGA and she is on a regular follow-up. This is how she was growing actually. And in the recent visit, the parents are happy that finally the child is catching up with the growth. Okay, so this child, if you see, the child's height was always tracking along the 3rd percentile, and in the recent this one, it is been increasing. It is crossing percentiles. Same way, you can also see there is a small amount of high weight catch up as well. Okay, and mother is worried that she has been noticing a breast development for the past few months, and they are asking now like whether it is of a concern. So we will come to that. We will come to the same case after we see, what is precocious puberty and all those things, whether it is of a concern or not. We will be discussing about that. So the overview of today's presentation will be to define precocious puberty, its classification and etiology, pointers, clinical and as well as biochemical pointers, implications, case scenarios. Along with the case scenarios, I will be telling you the management also. And finally, I will be winding up with the approach to precocious puberty. So what is more important is, we have to be aware of, how to perform an SMR assessment. There are totally 5 stages in the SMR assessment. Stage 1 is typically prepubertal, and stage 5 is an adult-like formation. Stage 2 in boys, it is increase in testicular volume more than 4 ml and the appearance of fine hairs in the base of penis. In the girls, it is appearance of breast bud called as thelarchy and also appearance of fine hairs in the inner aspect of labia majora. So after that 3-4, it will progress further. And then, the secondary mount regresses in girls, that is in stage 5, testicular volume becomes 25 ml, that is in stage 5. So one has to have this orchidometer in order to assess the testicular volume. It is easily available in the ISPAE website, so one can pay the money before and you can get it at your doorstep. It is couriered. So how precocious puberty is defined? It is the appearance of secondary sexual characteristics before the age of 8 years in girls and 9 years in boys. Overall incidence is like somewhere between 1:5,000 to 10,000. It is more commonly seen in females, at least 10 times more. So how to classify precocious puberty? So you have this physiological or an incomplete variant, which is premature thelarchy, premature adrenarchy, premature menarchy, and then you have true or central precocious puberty, and then you have the peripheral or the pseudo precocious puberty. The peripheral precocious puberty can be isosexual, means boys showing typical development of boys' secondary sexual characteristics. It's called as isosexual. Boys developing gynecomastia or the other gender characteristics is called as heterosexual. It's coming again. Okay, so central precocious puberty, how does it happen? You have the biological clock and you have the axis, hypothalamo pituitary gonadal axis. So this gets activated, your gonadotropins FSH, LH and is produced, and that acts on the testes and the ovaries to produce testosterone and estradiol. This is what is causing the secondary sexual characteristics, increase in testicular volume, increase in uterine volume, breast development, etc. So because the axis is activated, the initial gonadotropin secretions are in the form of a pulsatile nature, as you can see here. And when you stimulate with the GnRH, this level gets stimulated. Hence, it is also called as gonadotropin dependent. This kind of central precocious puberty, which is gonadotropin dependent, follows the normal sequence of puberty, and they are usually isosexual. In girls, it follows the order of thelarchy, height spurt, pubarchy, and then menarchy. In the boys, it is increase in testicular volume, followed by pubarchy, height spurt, and then they increase in the testicular volume to an adult level. What is peripheral precocious puberty? You have this hypothalamo-pituitary gonadal axis, but it is not activated. But the pathology is with the end organs like your testes and ovaries, which produce so much of testosterone or estradiol. And you also have the adrenal causes, which produces like a CAH or something. So which produces more peripheral androgens that actually inhibits the or suppresses the synthesis of gonadotropin, FSH and LH. So if you look at the FSH and LH level, they are unstimulated, and even if you give the GnRH, it is not getting stimulated at all. Hence, it is called as gonadotropin independent. So this type of peripheral precocious puberty usually have a discordant pubertal development, which means this does not follow the normal sequence of puberty, and they can be isosexual or heterosexual. Central precocious puberty, mostly it is isosexual. 99.9% it is isosexual. So incomplete or normal variant, I am not going into the details of it. This is a, either name anything, thelarchy, premature adrenarchy or premature menarchy. These are isolated events. It is not associated with the progression of puberty. Bone age is usually in the normal range. And you have your sex steroids and the LH levels especially are in the pubertal range. Sometimes these kind of the normal variants happen because of a transient activation of the HPG axis, or sometime it may progress into precocious puberty. So these children needs a follow-up. You have to keep these children under close follow-up in order to pick up the development of precocious puberty as early as possible. So coming to etiology of precocious puberty, so we have central and peripheral precocity. Central precocity is more common in females, at least 10 times more common, and then and idiopathic is always more commonly seen in female. In male, 90% of the time you can identify an organic cause. And what are the organic causes? It could be congenital anomalies like an arachnoid cyst, hydrocephalus. I want to emphasize on the presence of hypothalamic hematomas. And then you have acquired causes like abscess, chemotherapy, infections, inflammations, etc. And you have the tumors, LH secreting adenoma, astrocytoma, craniopharyngiomas, etc. Now coming to peripheral precocity, so this is like testicular, ovarian or adrenal causes, to put it simply, and you can classify it as genetic disorders like CAH, LH receptor activating mutation, DAX1 mutation, McCune-Albright syndrome, tumors, adrenal tumors, gonadal tumors, and these are limited or reversible forms like chronic primary hypothyroidism. If you treat hypothyroidism, this is going to revert back, and exogenous sex steroid, ovarian cysts, etc. So how to evaluate precocious puberty? Like in any case, how we evaluate? Detailed history taking with a special mention to know how was the growth pattern previously and now. Okay, and past medical history, any CNS insults, drugs, developmental milestones. I want to highlight that children who are having ASDs, ADHD or other development delay like cerebral palsy, these children are at a higher risk of losing the GnRH inactivating neurons. That's why these children are at a higher risk of getting precocious puberty. So asking a typical developmental history is very important. And family history, the patterns of puberty in the first and second degree relatives, whether any heterosexual manifestations are there or not. Physical examination, height, weight, BMI, height, velocity, if previous records are available. Like in our introductory case, we had the previous height records. So we know that the child has jumped off the percentiles, isn't it? And compare the current height with the mid-parental height. Check vitals. You may find a clue surprisingly regarding raised ICP or a CAH. And neurocutaneous markers, acne, capillary spot, myxedematous face, thyromegaly, which can suggest hypothyroidism, abnormal visual fields, eye movements, abnormal neurological signs, and a Tanner staging. Look for any discordant pubertal development in the boys. The penile length and girth needs to be measured, because this is an evidence of that there is a precocious puberty happening. How to evaluate? The first line or first correspondence should be given to bone age, because the height age is increasing, the weight age is increasing. What is happening to the bone age, we have to find out. So bone age is a rough measure of tempo. So fast growers, they are going to grow quickly, enter puberty early and stop early. And bone age advances more rapidly with puberty. So usually we take the left hand and wrist X-ray to include all carpals and phalanges, and we use Grulich and Pyle or Tanner-Whitehouse method for estimating the bone age. So the normal range is considered as chronological age plus or minus 2 standard deviation. So once the puberty happens, as you can see, see, this is how the epiphysis grows. So once the epiphysis widens, it's kind of starts having secondary calcifications and all, and then this kind of capping happens, and then finally the bone gets fused like this. So once this fusion happens, which is what is happening in puberty, so once this fusion happens, there is no further possibility of growth. So precocious puberty, the child is going to grow fast and also stop growing faster. The second line is doing a basal FSH, LH, estradiol and testosterone. So a basal LH, we have more sensitive assays available now. Basal LH level more than 0.3 is suggestive of central precocious puberty. Proceed with a stimulation test if required, and do an MRI brain. So GnRH, gonadorelin, is not available. So we use GnRH analogs only. So it could be leuprolide or triptorelin. Leuprolide is my favorite. So it is given in the dose of 20 microgram per kg per dose, and maximum is 500 micrograms as a subcutaneous injection. You take a basal sample, FSH, LH, your sex steroids, and 3 hours and 24 hours sample. And we interpret the stimulated level LH more than 5 units and an increase in the estradiol or testosterone level, which suggests HPG activation and central precocious puberty. Now, if the estradiol or the testosterone only is elevated with a normal or a suppressed FSH and LH, it is peripheral precocious puberty, and you do the imaging studies like an ultrasound abdomen, pelvis to look into adrenal and gonadal morphology. And also thyroid function test is very important. We have a case coming up in the case scenario section. And adrenal hormones, if you suspect like a CAH or an adrenal tumors. So others very rarely, HCG, which is actually like your FSH and LH. Any HCG secreting tumors can also once again present like a precocious puberty. Mostly it's a peripheral cause. Imaging studies, MRI brain and pituitary we do to rule out central precocious puberty. We look for the pituitary morphology, stalk morphology, cella morphology, any intracranial space occupying lesions, etc. And ultrasound abdomen and pelvis. Uterine volume more than 2 ml, ovarian volume more than 1 ml suggests the onset of puberty. And endometrial thickness more than 3 mm suggests that there is going to be an imminent menarche. And ovarian morphology also one can be looked into for any cyst or tumors. Adrenal gland and gonads by an ultrasound or CT in cases of peripheral precocity. So case scenarios, this is a 3-year-old male child who is a known case of seizure disorder on multiple antiepileptics. The child was referred for increased genital growth by our neurologist for the past 6 months. So this is the height, head circumference and the weight here. As you can see, this child is very tall for his age. There is increase in the testicular volume and there is progression of puberty. He has axillary growth, axillary hair growth and as well as pubic hair growth. So this is the child's picture. As you can see, the penile girth and length are increased and there is increase in the testicular volume. So this is actually a central precocious puberty. Bone age is 7 years. Basal FSH, LH, testosterone are all elevated. MRI brain is showing a hypothalamic hematoma and the child is responding well to GnRH analog therapy. So this is a 1.5-year-old girl child. From 8 months of age, the child is noticed to have breast development. The breast staging is 3 centimeter bud is there, but there is no other signs of puberty. A1 and P1, axillary hair is not there, pubic hair is not there. This is this one. And if you look at the height progression is fine, like there is no crossing of percentiles and all. It is within the percentile curve only. So what do you think it is? Quickly. It is precocious puberty or not? Yes or no? No. Then what it could be? Yes. So it is a premature thelarchy. But be careful because may need a baseline estradiol and LH levels to confirm it so, and keep the child under follow-up to watch for any progression of puberty. Okay. So this is our introductory case. So is it of concern? This child who is growing along the 3rd percentile recently started increasing or crossing up percentiles. Is it of concern with the breast development? 7-year-old. Yes, isn't it? So, so this is what I have told again, and there is pubertal progression. See, there is pubic hair growth as well. Okay, so the puberty is progressing. So the child is in height spurt and the bone age is 11 years. FSH, LH, estradiol are all increased. If you plot the bone age here, you can see that the current height of this child at 11 years, it is coming out to be less than the 3rd percentile. Okay, and if we predict the adult height, it is coming to be less than 140. Okay, and the importance of it, the implications we will see. Okay, so importance of why we have to intervene in children with the precocious puberty. So because of the advanced excessively advanced bone age, the adult height is blunted and they land up to be a short adult, and you need to be of at least 148 centimeters in order to drive a vehicle. So either a two-wheeler or a car or something. So you have to be of that height at least. Otherwise driving is going to be difficult and the person has to be dependent on other person or public transport. So I think that is a disability we are talking about. And mental age, body age, chronological age disparity. Imagine 7-year-old having a mental development in a pool of sex steroids. So having a mental and emotional changes that are faced by a 13-year-old. Okay, and the body is also like a 13-year-old. So, it is very difficult to explain in words. So whatever the emotional damage the child is undergoing through. So that is another thing, and this leads to high-risk behaviors, and they easily succumb to peer pressure, and they have a lot of self-image concerns. So these are the reasons why you should actually treat precocious puberty. So central precocious puberty, we treat with GnRH analogs. So the predicted height less than the mid-parental height or the target height, it is an indication to start GnRH analog therapy in central precocious puberty, and also patient and family preferences. Suppose a child not growing well at all but landing up with an early puberty, you want to delay the puberty for some more time so that you are providing some more time for the child to grow. So these are individualized, these reasons are to be individualized for every patient and to be treated. So when you give GnRH analog, what happens is it blocks the GnRH receptor. So initially there will be a small stimulation and the production of FSH LH happens, but later on it leads to down regulation and desensitization so that there is no pulsatility and the FSH LH secretion decreases. So leuprolide and triptorelin are the two drugs that are available in the market in Indian scenario. So you have 4 weekly preparation and you have 12 weekly preparation. Both these drugs are given as IM injections. So monitoring, clinical assessment only, and adverse effect, injection site reaction, sterile abscess can happen, And the long-term side effects, the studies are needed actually. The 20-year study following, GnRH analog therapy and all is not available, so we need those studies. And the discontinuation of treatment, it is impossible to say like, use this parameter, if it is achieved, you stop the medication. So always consider the patient preferences and aim for menarche close to the population mean. So 5.5-year-old male child having facial and pubic hair growth for the past 2 months, acne for the past 2 months. So I hope you can see the acne here. And this is the pubic hair growth, increase in the penile length and girth, and the small testicular volume. You can notice you have small testicular volume. I'll just finish in another 2 minutes. So the SMR, you can see that axillary hair and pubic hair is severely advanced, and the testicular volume is only 2 ml. Stretched penile length is 8 centimeters with increase in the penile girth. So what he has is a pubarchy with prepubertal testicular volume and increase in the penile girth, which is typical of a discordant puberty. Okay. So puberty has started first, but the testicular volume is not progressing. So this is a discordant puberty. So this is called as a peripheral precocious puberty. And this child was found to have a virilizing adrenal tumor. You can see the virilizing adrenal tumor here with all the hormone levels, adrenal hormone levels were so much elevated. So 8-year-old girl, this child was referred for a short stature and constipation. I hope you can make out the increase in the the appearance of thelaki breast buds. And she is short. Look at that, only B2 is there, no other pubertal progression is there, goiter is there. So this is a typical syndrome due to chronic untreated hypothyroidism called as Van Wyck-Grumbach syndrome. And one can have presence of ovarian cyst, multiloculated ovarian cyst in the ovaries if you do an ultrasound. So this child had an autoimmune hypothyroidism. And this is a 2-year-old female child who was brought with vaginal discharge for the past 6 to 8 months. You can see how much vaginal discharge is there. And axillary hair growth for the past 4 to 5 months of age. And I can see only these 3-4 capillary spots in the body. Any implications? There is no significant increase in height and all. The child was following the centiles. So it's a peripheral precocious puberty due to McKeown-Albright syndrome. And the FSH LH levels were prepubertal, no response to GnRH analog stimulation, but estradiol is elevated. And there is a ovarian cyst in the ultrasound, and the child had a GNAS mutation positive, which is typical of a McKeown-Albright syndrome. So treatment of peripheral precocity, treat the cause. If there is a tumor, you excise it. CAH, replace with steroids. Treat hypothyroidism. And for McKeown-Albright syndrome and familial progressive puberty, you can use aromatase inhibitors or a selective estrogen receptor modulators. So I'll wind up with the approach to precocious puberty in girls. So based on whether the child presents with thelaki or menarche or pubarchy. So if the bone age is advanced in a girl child presenting with thelaki or menarche, look at the LH levels. If it is in the pubertal range, it is central precocious puberty. You go with your imaging studies. If it is prepubertal and the estradiol alone is elevated, so do an ultrasound. If it is ovarian cyst or a neoplasm, you excise it. If it is negative, then it is most likely due to exogenous estrogen. If the bone age is equal to chronological age, it is premature menarche or thelarche. Again, a child presenting with pubarchy, bone age is advanced, 17 OHP is elevated, CAH. 17 OHP normal, but DHEAS is so much high, it is adrenal tumor. And bone age is not advanced, then it is premature pubarchy. Shall I change? We have to go. So in approach to the boys, so do a history, physical examination and bone age. Increase in testicular volume plus the presence of pubic hair growth. If the bone age is advanced, it is again, as mentioned in the previous slide, it is CPP. And if it is prepubertal, only the testosterone is so much elevated, then it is testicular tumors. If the imaging is negative, then you have to evaluate for McKeown-Albright or a familial male progressive puberty. And if the beta HCG and AFP is elevated, hepatoma and HCG secreting tumors should be thought of. Bone age is advanced in a child presenting with a normal testicular volume and puberty. So this is CAH, 17 OHP is elevated. If the DHEAS is more elevated, then it is adrenal or a Leydig cell tumor. Do the imaging then. And if the bone age is not advanced, then it is premature puberty. I hope I have given a clear impression. And we were talking about the heterosexual manifestations. So if there is a heterosexual manifestations, you always think about ruling out a tumor. The HCG tumor can be anywhere starting from head to toe. So and also the gonadal tumors and as well as the adrenal tumors. So thank you all for your patient listening.
Thank you, madam, for your detailed and excellent presentations. As madam told, any precocious puberty in females is mostly idiopathic, and in case of boys, we have to rule out virilizing tumors. Madam, how long for GnRH analog, how long we can give? Because we had a child with 5 years with a precocious puberty.
Okay, sir, if you have diagnosed, I also have a 2-year-old with a hypothalamic hamartoma, and the child is currently only 5 years old. So you can give it for a prolonged period of time if, the presentation has started early. You can always give for a prolonged period of time. But there is something like if you are starting early, suppose you are catching up a child only at 8 years of age, and you want to treat the child because of the compromised adult height or so, I think a minimum of 2 years is compulsory. So if at all you want to augment the height, a minimum of 2 years therapy with the GnRH analog is compulsory. But younger the age, you have identified with an organic cause or something like that. I think there is no one parameter like height within the normal range. If it there means you need not stop. By 8 years, if the height comes in the normal range, can you stop it because the child is going to progress with the puberty? And by 10 years, the child is going to have its menarche. So just take into consideration whatever the parental concerns are, and as well as the child should have an menarche, or the child in a boy child, the boy should start having facial hairs at an age appropriate time as per the population. So that is more important.
That was a 5-year-old child with a lot of pubic hair with increased penile volume and length. The parents are more concerned. We started on a GnRH analog, but we don't know when to stop or this thing.
You can actually continue it for a long period of time. I would say in your case, maybe stopping at 11, 12 years of age will be an ideal time, because peripheral precocity, sir, or hypothalamic hamartoma? It is
idiopathic, madam.
Idiopathic, okay. So, but it is a central precocious puberty.
Yeah.
Okay. So in that case, I think you should, for boy child, you should at least take the TRIA therapy for at least 11 years or so. Because by then, it depends on how advanced the stage already is. Because the moment you stop GnRH analog, in a matter of 3 to 4 months, the child will progress into puberty. So that is there.
So what about that precocious puberty with standard growth? What about growth hormone replacements? Is there?
So generally in hypothyroidism, you are talking about hypothyroidism, sir, or in a child who is already short?
Already short.
Okay, the child already, like our introductory case, yes. So yes, if the child's height gain is not in the correct trajectory, I think supplementing with growth hormone might be needed. But as I said, 1 to 2 years of therapy will tell you how the child is progressing, and then we can take a call.
Thank you, madam. Thank you for the excellent presentation. Any questions
from the floor? If there are no questions, we'll move on to the next session. Thank you, Dr. Subhash sir and Dr. Dhivyalakshmi ma'am, for this wonderful session.